Dan Judge, Mike Gibson coming to you live from AHA 2024, and we're talking about repeat hospitalization in the Attribute trial, a trial looking at patients with amyloidosis. Talk to us a little bit about what you did and what you found, Dan.
Yeah, we're very excited, Mike. Thanks for the opportunity to share this. We did our initial Attribute CM study of Acoramidis versus placebo for ATTR cardiomyopathy and showed those results last year. Of course, it works, and our analysis there was the four-component win ratio, the Finkelstein-Schoenfeld method, and no question there. But the one lingering question was mortality. We didn't have a statistically significant result compared to placebo at 30 months. So now, open label extension for an additional year out to 42 months. I'm really pleased to show that we have now a very clear mortality benefit with treatment with Acoramidis compared to placebo. The other big takeaway from the—
And can I ask you a question in there, Dan?
Sure.
Was there
Yes.
crossover between the placebo arm and the Acoramidis arm, or no?
No, they separated but didn't reach significance at 30 months. And by the time we got out to 42 months, our p-value was 0.0059, hazard ratio of 0.64. So really looking good for a primary single event, the all-cause mortality analysis.
So does this change things? Where do you see the molecule fitting into practice?
So first of all, it's still investigational, but we will have a report from the FDA soon in terms of being able to prescribe it. I'm very hopeful, and I strongly expect that they will agree to approve Acoramidis for ATTR-CM. And it certainly is a next generation stabilizer. I think one of the temptations for all of us is to compare it with other drugs that are out there for this exciting disease for ATTR-CM. And those cross-trial comparisons are not available, right? Or I don't like to use them, I should say, because they're really not valid. But it's another very effective therapy for treatment of ATTR-CM.
Different patient populations, different risks, different designs of studies, different durations, different endpoints. Trying to compare them is like fruit punch. Very hard to put it all together, right?
Well, yeah, but one additional thing we can take away, and this applies for all therapies, but what we show in our open label extension is that the earlier you start treatment, the better it is. In other words, people who started late had far less success or benefit from Acoramidis, and the same is true in tafamidis and prior studies and others.
Your basic science is only as good as your implementation science. Look forward to seeing what you can do to get it implemented earlier in upcoming studies. Dan, thanks for joining us here, and thanks to all of you for joining us live here from AHA 2024.
Thanks.